Okay.
Sorry for the delay, everyone.
Okay, cool.
Hi, Gaz.
Hi, sorry, got caught in traffic.
Okay, that's good. Excellent.
Matt, I might hand over the chair to you.
Okay, who have we got there? That looks like Rooney, is it?
Yeah, we've got Rooney Jaglee, Kennedy James from PNG,
Yep.
and Fiok. I'm not sure who Fiok is.
Who's Fiok in Gizo?
I am Mike.
Mike. Hello.
Oh, Mike Bowen.
Yeah.
Yeah, good.
Yeah.
Mike Bowen, General Surgeon.
Okay. Hi, Mike.
Hi.
We'll wait for a few more people to come on.
Mycket gamla liv.
So we can wait for a few more people, but we'll do whatever you guys want to do. But I've got a short presentation on basically how to write and how to get a paper published. And Peter Hewett's going to talk a little bit about data collection with some suggestions about data collection. And Chris and Konrad, if he logs on at the end, we'll just have a general discussion about ideas for research. So, but let us know what you want. We'll wait a few more minutes before we start, because I'll do the presentation on how to write a paper, which hopefully will be helpful. It's a sort of practical thing about getting ideas for papers and how to actually get it published. So I'm not sure if that's what if that's not what you want, just let us know, because we can talk about anything. So, Rooney, do you think there's likely to be more people or not?
People might still be in the theater, so I'm not sure.
That's all right. Well, I'm happy just to start. So I've got it. I'll go to share screen, and I've got it. So it's basically a presentation on how to get a paper published. It looks like everyone there's at different levels of their training and career. So this is sort of, I think this is set, well, it's set at any level really, if you want to get a paper published, about just having ideas and how to actually go through the process. So let me just share the screen. So can everyone hear me okay?
Yes.
Yep. So I'm Matt Rickard. I'm a surgeon in Sydney. I'm a colorectal surgeon I've got a university appointment at Sydney University. Chris Berney is there, who's also a surgeon in Sydney with a university appointment with UNSW, Chris?
Yep.
Yep. And Peter Hewett's joining later with a university appointment in Adelaide. And Konrad, where's Konrad from, Gary?
He's from Invercargill in South Island, New Zealand.
So we're all kind of trying to be academic surgeons, but obviously that's difficult. So I think I'll start with this is a quote from the editor-in-chief of the Lancet saying that academic surgery is an oxymoron. So I think this guy's an idiot. Because you can do academic surgery, and in fact, academic surgery is quite important. This is just a sort of slide of some of the academic surgeons of the past. So Richther, who invented antisepsis, this guy who worked out that lumpectomy versus mastectomy are similar. The guy on the bottom right who looked into CAR T-cell therapy long before most of the hematologists, and this guy who's won a Nobel Prize for a renal transplant. So academic surgery is very relevant and very possible. And this is always the stumbling block. And we're going to talk to you a bit about this because having data is the king. In terms of if you want to do anything academically, you need data. And Peter will talk a little bit about this, but you guys will, the interesting thing is you guys will already have a lot of data in your hospitals. And sometimes it's just a matter of leveraging that local data that's already there. But data is the king. If you want to actually write papers and do research, you need to know what you're doing, and you need to know what your outcomes are. So that's often the stumbling block everywhere. I guess we'll just go through a few of these things, getting your paper published. So a few things, why bother, what to do, and some comments about writing and submitting your paper. So why bother is quite a reasonable question. And it depends where you are, but as a trainee, certainly in Australia as a trainee, it's very important to get publications for your academic advancement. I don't know how important it is in the South Pacific, but if you're a trainee in Australia and you want to get teaching hospital jobs, it's actually very important to publish. It's a bit of a shame because sometimes publications aren't that relevant, so you try and keep it relevant, but publications are very important for a trainee. Most of our, the college and the post-fellowship training boards, it's a requirement to at least do one publication and one presentation. And I think every surgeon should really have this sort of thirst for knowledge, and every surgeon should be an academic surgeon. So you should, even it's as simple as actually knowing how many cases you've done and what your outcomes are. You need to develop that interest, and you need to know what you're doing. It will give you a competitive advantage when you're a registrar or as a fellow or consultant jobs. Certainly in Australia, research is the king in terms of advancing academically. What about for consultants? So I think for consultants, if you've already got your job, you might think, I don't need to do any research because I've achieved my aims, but it's important actually to pass on that knowledge. You should, I think, have that sort of curiosity. As I keep saying, you need to know what you're doing and what your outcomes are. You should be curious about that. You should want to improve patient outcomes. And it actually is good for your job satisfaction if you're doing some research and doing some publications and you understand your own outcomes. It's very helpful when talking to patients. If you propose an operation and they say, what are your results? To be able to actually flick a switch and know what your results are is very useful. CV enhancement, as we've talked about. And it is actually giving back to the community in terms of if you're publishing useful things, you actually are being altruistic as a surgeon. Confucius said, choose a job you love and you'll never have to work a day in your life. He also said, man who goes to bed with itchy bum wakes up with smelly finger. So why not do research? So this is most people's excuses. So negative impact on income and family. So we're all short of time. I'm not sure what it's like for you guys, but if we don't work, we don't make any money. So if you're taking time off to do research, you're losing income. Taking time off to do research, you're spending less time with your family. You often don't get a lot of help from administration. And often you don't get any funding. So getting funding for big research problems is always is our battle constantly. This is a real picture apparently of the peak of Everest one day a few years ago. So there's a lot of competition even as a consultant to get to the top. So I guess that covers why bother. So it's worthwhile. It actually is quite enjoyable doing research and getting papers published. And it is very important for academic advancement. So I think it's worthwhile, and I think it is worth bothering. So the next thing is what to do. So what do you actually do about it? And these are the sort of different types of research that you can do. So basic science and translational research really just means getting that basic science research into something that involves patient care. Clinical research is probably going to be relevant for you guys. This outcomes and health services research, that's where I mentioned there's probably a lot of local data in your hospitals that you could leverage to look at outcomes. Global surgery research and education research. So if you guys are teaching junior doctors, there actually is often a way to evaluate how you're teaching and whether that's useful, and if you've got any new teaching methods, how to improve it. So this slide's kind of important. These are the sort of research you can do. For you, it's probably going to be clinical research and outcomes research. So with clinical research, basically this involves obviously clinical questions using human subjects. And this is the range, and you guys know all this because you read the literature, but basically, the weakest evidence is just case reports, and then you can do reviews. Reviews are always nice to do as registrars. You can do a narrative review, which is like a systematic review, which is not as good as a systematic review. A systematic review or a meta-analysis if you've got appropriate statistical support. An audit, a prospective or a retrospective cohort series, and the ultimate research is a randomized controlled trial, which is difficult to do unless you have a big research setup behind you. So in terms of outcomes research, that's really at a sort of hospital level to see if any specific healthcare and interventions that you do are actually useful. So examples are comparative effectiveness, cost effectiveness research, which the administrators love if you can prove something is cost effective, and quality of life research. Health services research, again, at a bigger level, investigate how various factors act separately and together to affect delivery of healthcare and health and well-being of individuals. So this is something at a sort of area level or a country level or an island level, examples of how you educate your patients, what are the patient outcomes, what's the quality, what's the patient safety, and what's the access and equity and utilization of healthcare. Education research is something that's accessible to everyone. Anyone who's teaching registrars can think about new teaching methods, can evaluate those methods. And really, we're all teaching all the time. I think every clinical activity, every clinical episode is actually an opportunity to teach. So when you're on the ward, even if you're seeing a patient, if you're with the nurse or if you're with your registrar, you should think, in terms of teaching, you should think that every time you're doing anything with a patient is an opportunity to teach. And it's important to remember that, I think. This is something that I'm not sure how practical it would be in your environment, but it's something that's getting bigger. Initially it was in the UK and now in Australasia. So these trainee research collaborations, because as you know, a lot of registrars try and do their one little trial or their one little case series, and it doesn't amount to much. Whereas if the registrars can get together over a few hospitals, they can actually get really good publications going. And it's something that may be possible around your area, but it's all about communication. It's usually about one registrar taking the lead. And in the UK, they've got this National Trainee Research Collaboratives, and they're pumping out a lot of really good papers, and they involve registrars at each hospital. And the important thing is they all get listed as authors on the publication. And in Australia, Australia and New Zealand, there's a clinical trials network, which has just started. And that's an example of something from the UK version. So they can very quickly, if you communicate properly across hospitals, you can very quickly get a whole lot of patients for a study. And it probably is the future of research, really. And it avoids those small little studies that we often do as registrars, which don't amount to much. So if there was some way you could coordinate all the registrars across your areas, that would be fantastic. I'll get rid of that. So if you think about the research process, this is the way you need to think of it. So obviously you need to have an idea, and we'll talk about some ideas at the end. If ever you have an idea, what you immediately need to do is look at the literature, because you might find that everyone else has had your idea and it's not as big an idea as you thought. Or you might find there's nothing there, or you might find that there's some information there, but there are certain aspects of it which are lacking, which you can research. So very important, once you have your idea, to find out who else has had that idea. Then you need to create a question and generate a hypothesis. Then you need to work on the study design. Then you need to develop a protocol. You need to get ethics approval. You may or may not need to seek funding. Then you need to collect and analyze the data. You need to interpret the data, and then you need to disseminate the findings. So that's the basic research process. The important things along the way, right on, is, if possible with your study design, if you can, get a statistician involved early, and get your ethics approval early. So nothing, in terms of when it comes to the end of the road, when you want to get it published, if you haven't got ethics approval, most of the journals won't even accept it, won't even look at it. So I'm not sure how your ethics process is, but that's something that needs to be thought out early. So we've covered why bother, what to do, and what about actually writing and submitting your paper. So the writing is difficult and tedious, but it actually can be enjoyable. If you've had a good idea and you've gone through the process and you've got the data, it can be enjoyable. And you really start with this. So you start with a blank piece of paper and you've got to fill in the dots. You've got to have a bit of structure from your idea to the paper. The sort of overview of the process is the preparation, the writing, the submitting and revision. Very important at the beginning to get organized. So if you have co-authors, you need to meet your co-authors. You need to actually set aside some time to actually write the paper. Ideally, you should give yourself a bit of a timetable. So you should say, right, I'm going to have the first draft by date X, because otherwise these things just get left and months pass. And you need a system for version control. So if you've got a few co-authors, especially if you've got a senior author, you'll send it to the senior author, and the senior author will probably ignore it for a few weeks and then make a few changes. And if you've got a few authors, they'll make lots of changes. So you've just got to have a system on your own computer of keeping track of all those versions. And when you're writing it, you've really got to work out what your key message is. That's possibly the most important thing. So when you think about how you read papers, we all get the journals and we leaf through them and we maybe look at a few abstracts. Very rarely we read the whole thing, but we're always looking for the key message. So what's the key message of this paper? How will it change practice, if at all? When you're choosing the journal, you've got to think of the audience. And authorship's important. And I think it's very important to clarify authorship early on. You don't want any fights amongst registrars or senior authors as to who should be an author on this paper. So clarify very early who's going to be the author of the paper. No, you should know about impact factors. So Annals has got the highest impact factor of surgical journals. I think ANZJS is way down. So you sort of aim high, but you've also got to be realistic. When you think of the journal, is it of general interest to general surgery, or is it specialty specific? So I'm a colorectal surgeon, so we tend to write a lot of colorectal articles, which we try and publish in the diseases of colon, rectum, or colorectal disease. If we think it's really good, we might aim for Annals or JAMA or New England Journal. Usually we fail. So it is worth knowing about those impact factors, and it's important to be realistic. So what you've got to do once you decide on what journal you're going to publish in, all journals will have instructions for authors. It's very important to read those before you write it. So they might have word limits. They'll have suggestions about the structure of the paper. Get your abstract together, get your literature review together, work out which journal you're going to go and get the instructions for authors. And this is a quote just saying, knowing where to begin is sometimes the hardest part. So sometimes when you're writing a paper, you put it off, you've actually just got to start. And you just start, and even if you write rubbish at the beginning, you've just got to start writing something, and then you'll get going. And you can start with a blank sort of template. So you've got introduction, materials, methods, results, discussion, and we'll go through each of those. But basically, you can start with that template, and you can fill in bits and pieces along the way. You've got to, as I said, like when we're reading journals, we want to be able to leaf through it and get the message. So it's got to be written in like a story that's easy to follow and understand. It's got to be logical. It's got to be precise and concise. And I think it is worth being systematic and working on one section at a time. You possibly should start. You don't have to start at the beginning and then go through sequentially. You can start with the discussion. But one section at a time, and don't mix things up. So the methods needs to stay in the methods, the results needs to stay in the results. And you can't be repeating methods and results in the discussion. And this is a quote from Einstein, and it's true, if you can't explain something simply, then you probably don't understand it. So you should be able to write this paper so that someone who's not that familiar with it can read it and get that key message. And this is the type of manuscript format. So you've got a title page, you've got an abstract, you've got the body, which has the introduction, methods, results, discussion, acknowledgements, references, tables, figures, and legends. So every journal's got that same structure. And the introduction's got to be something that'll make the reader slightly interested. Okay, so the reader may already know a lot about it or they may not, but basically you've got to bring the reader up to speed on the topic, and you've got to tell them what the aim of the study is. So a little bit of background, something to pique their interest and let them know the aim. And there are subheadings of introduction. So what is known, what is unknown, and what are your aims and hypotheses? And in your materials and methods, you've got to just clearly define what you've done. You don't want to be too verbose with this. Use figures and flowcharts to complement things rather than repeat things. So someone needs to read that paper, and if they want to repeat that study, they need to be able to work out how to do it from what you've written. So they shouldn't need to contact you to repeat the study. This is materials and methods. So you should start with your study design. Who were the participants? What procedures did you do? What were the variables and the data? Talk about your interventions and exposures. Explain your statistical methods. Mention that you've had ethics approval. And the results is really the key section. A lot of people don't end up reading papers fully, but it's important that if they do read the results, they can see exactly what's going on. So this is the key section. So you guide the reader through text, tables, and figures, and you don't have any discussion or any methods in the results. So that's sort of just an outline of the results. You can have tables and figures. Again, they shouldn't repeat what's in the results text, but they need to be clear. So you need to be able to look at a figure and clearly see what's going on. Figures are beautiful if they're set up properly. And in the discussion's important. A lot of people only read the discussion. They might read the abstract in the discussion. So you've got to discuss your findings. You can't put results in there. You do mention what the key finding is. Talk about could it be wrong. Explain why it's useful and who should care about your results. And there is a structure to discussion. Paragraph 1 is summarize. Paragraph 2, 3, compare with other studies. You should always address every study that you do will have limitations, and it's better to address them rather than have the reviewer address them for you. And you've just finished, usually just finish with one paragraph with your conclusions. Editing, this depends how many people are co-authors, but you actually, the next slide shows, I think, yeah, this is what you often end up with. So you've written a paper, you might be the junior author, you send it to the senior authors, there might be three or four people who make lots of changes. So expect lots of edits. And sometimes it's quite frustrating with, certainly when I was younger and I was writing papers and giving them to senior authors, it'd go through this cycle where you'd end up back where you started, which was frustrating, but you've got to not take it personally and you've got to maintain collegiality with your co-authors. So make sure everything's right before you submit it. And then you'll send it to reviewers. And this is the sort of outcome you can expect. So it's very rare for a paper to be accepted without any revisions. So if you do that, you're a legend. Often you'll just get minor revisions. If you get a thing back that says minor or major revisions, then you're probably going to get it published. You can have reject without review, which is a bit depressing, and maybe reject after review if you've made a few changes. But if you're in these first three categories, usually you're going to get it published. And the next bit's important because the reviewers, like I review papers for the ANZJS, and I'm what would be called a soft reviewer, but some reviewers are quite hard, and they almost feel like they have to say something to make themselves sort of relevant. So sometimes it's very frustrating when you get the revisions back and they make suggestions which you know are never going to be possible. But as I said, if you're in one of those first three categories where it's accepted or minor revisions or major revisions, you're probably going to get it published. And you've just got to take the time to respond to each comment in the reviewer's review in a logical manner. It's never helpful to write back and say, this is a stupid suggestion. Never helpful. It's usually not helpful to argue with the reviewer. It's possible, and Chris will comment on this a bit as well, but it's usually more helpful if you say something like, I'm very grateful for your opinion, blah, blah, blah. And then sort of, you can say you don't agree with it, or you can, but you've just got to respond to all the reviewers' comments. Chris, do you want to comment there?
No, actually, I agree with you. It's always good positive comments, and you go in the sense of the comments. But sometimes a comment can go in the wrong opposite direction that what you want to show or what your result shows. I think it's not wrong to try to argue, to say, well, on steroids saying, but I would disagree with this change because A, B, C. And I think if you get good arguments to say why we would disagree with one of the comments, I think it's fine, they will agree. It's acknowledging what the comments are, it's good, it's always for the better, but sometimes you don't always agree with everything. And when I do myself review papers and I do make some comments, they're not necessarily accept everything I've said. They just they will actually argue if there's a problem, but it has to be done in a constructive way and so forth. So I don't think it always the reviewer doesn't know necessarily as well as you know the paper you just published. So I think it's being mindful that they're here to help you, acknowledge what they say, but you don't have to agree to everything. That's what I would say. Yeah. Yeah. So the difference with what you said, I think that it felt that you want to embrace all the comment they make and implement what they say. Not necessarily. It's not wrong to disagree sometimes.
Yep, I don't know if Peter or Konrad got any comments there.
Can you hear me? Good evening.
Yep. Hi, Konrad.
Good evening, Rooney. I see you. Right. And who is next to you?
Denton.
Oh, Denton. How are you?
I'm good. Thank you.
Well, thanks for the nice overview, Matt, about writing and I agree with everything. We all went through dark days when our papers got rejected and we felt useless, and we also sometimes felt the reviewer doesn't have a clue what we were talking about. And then you learn over the years how to respond in a nice way, but you also can keep your mana. I mean, you can accept the criticism, but can also take a stand for the things you know, then the reviewer possibly looks bad to some extent if you have a strong point. It needs some effort to write this, that it gets accepted, then you don't have to burn any bridges. But I was wondering what you guys would say. I mean, Matt and Chris, I copied you into this email about the research projects we did a few years ago. We started actually with Stanton. I spent a week in Kira in Makira. And you remember this?
Yeah.
And we did some shoulder ice procedures, and I thought that would be one of the 6 or 7 projects we were trying to tackle. It turns out in the discussions that there are actually no data really collected in the Solomon Islands. There is no data registry, or if it exists somewhere nobody knows really. And that's where we were going to start, to try to collect the data which would be already unique for the Solomon Islands, because there's actually not really any studies coming out of this country. Correct me if I'm wrong, in regarding to what kind of surgeries, what kind of complications, what kind of incidents for certain diseases. And you will remember that we looked at the high number of papillary cancer in thyroid, which we don't know how many there are. We also looked at the occupation of beds. Turns out that 70% of the beds are occupied with septic patients, and people don't even get into a bed because they're occupied by people who stay there forever, the septic complications. So we were looking at maybe research questions that are specific for this situation, how we can, you know, move these patients out of the hospital, have them treated outside of the hospital, free up the capacity. But in order to do this, we need numbers, we need statistics, we need bed capacity, we need numbers of operations. And I think that's when we realized that's extremely hard to get, Matt. And once these numbers are there, I think pretty much anything could be published, because there are no data that give us this information from the Solomon Islands with an interesting hypothesis, of course. You have to sell it properly, make it a sexy little project. But yeah, that was where we ended. I think that was 2 years ago now.
Peter, I'll finish that talk. If you want to, a lot of my talk is from this paper, which is how to write a paper. So if you want to take note of that, guys, and you can look back on that. But Peter, here you got any, I mean, what Konrad said there is, and what I mentioned in the talk, that data is king. Have you got any comments about how to collect data and any sort of suggestions about that, Peter Hewett?
Yeah, look, I've got a short PowerPoint I can put up if you like.
Yeah, I'll stop my share.
Okay. Okay. Hi, everybody. Nice to see you all again. Hope everything's good over in the Solomon Islands. Often wish I was there, to be honest. Look, just this is not going to take long, but I just thought I'd run through some points about data collection, and you'll see here that in terms of research, and this is just a rough figure, but really 70% of your effort in research is data collection, and about 30% is analysis. And you know, it goes without saying, without data, you've got nothing to analyze. So it's the starting point and the most important point for research. And of course, you have all of this data that you want to bring in and somehow make sense. So you've got to really pick what it is that you want to analyze, and therefore what are the questions you're going to ask. And that's terribly important. So in terms of the sort of data journey, this is just, I've just picked this one out. This is cancer registration. So it always starts with the patient. And of course it is always about the patient. So you've got to have the patient available, and you've got to have the patient willing to give data. So there is a consent process that then goes on so that the data can be collected. Once the data is collected, and you need someone to collect it, now that might be yourself, or it might be someone else. It may be another doctor, it might be a nurse, it might be data manager. They collect it in some form, and we'll look at that a bit later. And then it sits in the whatever it is that you have got it in whatever format. But importantly, it has to go into a secure system, and we'll talk about that as well. And then you get the data is analysed. So this is a business slide, but I think it talks about why data is valuable. So you have the raw data. That then gets reported, so you have standardized numbers, if you like, or standardized outcomes that you're looking at. This is then analyzed, and then the analysis looks at whether or not what you're doing is effective, and hopefully what can be changed. And that's sort of a business model. In health, there's a thing called a learning healthcare system, which I'll touch on at the end. So there are two sorts of data. There's quantitative data and qualitative data. So quantitative data is stuff that you can express as a number, like how many days did the patient stay in the hospital, or what was their highest temperature, or et cetera, et cetera. So qualitative data is stuff that can't be expressed as a number. So, was the patient angry? Was the patient depressed? Now, you can have sort of qualitative data like nausea that you can turn into quantitative data by having a score of 1 to 5, 1 being no nausea, 5 being extremely nauseated, for example. So quantitative data you can count, qualitative data you can't. Quantitative data is number and statistics. Qualitative
has never looked this good.
Words and objects and pictures and observation and symbols. So quantitative data, you can find out how many, how much, and how often, whereas qualitative data is how and why has this happened. For example, weight of a person, shoe size, etc. We've talked about that. Types of survey questions, mostly closed-end questions. The answers that can be turned into numbers. So, for example, how much pain have you got from 1 to 10? Open-ended questions with detailed answers without numerical value. Do you feel happy about your treatment? Would you come back and have further treatment? These days, the sort of latest and biggest push is things called, in data, is PREMs and PROMs. So patient recorded outcome measures, PROMs, and these measure the patient's view of their health status. And there are, large banks of these already formulated. And PREMs are questionnaires measuring the patient's perception of their experience while receiving care. And these are quite valuable, because more and more we're understanding that really, if what we consider as a successful outcome, in that the patient left home in 2 days and without any obvious complications, while we consider it a success, it may be that the patient's perception is such that, in fact, they had extreme pain on day 3, they felt lost, they had no one caring for them. The whole thing, as far as they were concerned, was a disaster. So more and more we're looking at the outcome of the treatment from a patient's point of view. Data collection. The age-old and simplest, of course, is pen and paper. You have a form, fill it in, and then it's stored. Advantage is that it's relatively low cost and simple. The disadvantage is that you then have to convert the information once you have it on there to something else. And indeed, that might be something like an Excel spreadsheet. That's very common, very widely available, and it does have the ability to not only store data on it, you can analyze the data in some forms. Then you have things like REDCap, Research Electronic Data Capture, and this is a little bit more advanced. So this can be done online, and it can be done with multiple people putting information in as long as they have the passwords, and it can be done prospectively, and it's stored in the cloud in a area that's secure. So for example, this is being used in some of the large scale projects looking at one is looking at outcomes of diverticulitis admissions throughout the world, with hospitals in the UK, Europe and Australia all putting information in onto this particular database. So the advantage is many, many different areas or sites can put in data. And then of course you can always build your own database, which is not quite as simple as it sounds, but that can be done. Importantly, with all data is security. And for example, if you've filled in paper form, that has to be locked in a secure filing cabinet so that only the people who are involved in the study can access it. Computer files, so if you've got it stored on a hard drive, these computer files must be password protected. And then cloud storage. I mean, REDCap, the cloud storage is very secure, but there are issues at times when you're putting data into various international databases that it may be stored off-site, and Australian ethics committees really frown on that, having the storage, when I say off-site, I meant internationally, having the storage internationally rather than in Australia. And if you're going to store anything on the cloud, you need to know what, if any, the Solomon Islands government has in regard to the storage of medical data and whether it can be stored on international cloud servers, and also what the security and privacy constraints are in regard to medical data. So it all sounds simple when you start, but the key is that you have to have accurate and complete data collection, and that, as we all have experienced, can be extremely difficult and frustrating. And the little slide that says rubbish in and rubbish out. So if you've got inaccurate data or incomplete data, then your outcomes aren't going to be meaningful. So it's so important that your data collection is accurate and complete. So when you start, you have to know who is going to collect it, who is going to be responsible for that. Importantly, who is going to check the data when it's collected, and what is the analysis and how is that being organised? So I mentioned about a learning healthcare system. So that's when you collect patient data, and that can be from a whole range of sources. The data is then placed in a server in the cloud. Then this data can be accessed by clinicians, or you can get data from electronic medical records, which can be accessed by the clinicians. This data is then put into a clinical registry, again stored in the cloud. and then looking at the cumulative results of the data in the clinical registry. For example, you can look at the first 50 hernia repairs you've done, and by analysis say that, well, for some reason, patients over the age of 50 aren't doing well. Let's look into that, change whatever it is you're doing, and then use that as a feedback loop to continue collecting data so that the results can be reanalyzed and see if what you've changed is effective. And that's called a learning healthcare system. So thank you very much. That's all I've got to say, but happy to take any questions.
Any comments from you guys regarding, you know, how to write a paper, how to collect data, any help you'd like with ideas you've already generated or idea generation? Any comments at all that we can help you with?
Okay, well, thank you very much for the presentations and the discussions that we've had, that you've given us, especially from you who are very experienced in publishing papers. I think for us, we have many challenges which have been mentioned. But mainly for our registrars, especially who are training, like Denton, who's with me, they have to write a paper as part of their postgraduate training in PNG or in Fiji. They have to write a paper at the end. I think this is a very important, useful lecture, and I would have hoped that most of my colleagues were here, but nevertheless, I think one of our biggest challenges is complete and accurate data collection. We do not have like proper database or data system that we have access to. But of course, if we want that information, we could collect that information ourselves and then have it looked at. So I think going forward, I think with your help, I think we could look at some topics like we tried to do with Professor Konrad previously, which we failed on our part, but perhaps we could look at some topics and share among ourselves, and then write some basic proposals and perhaps share with, we could get some people, maybe work with each of you and go forward and help us to having the process of writing papers, and perhaps with your help we could get on to publish some of these topics. So perhaps we would come up with some areas of interest, and then see if we could write some common papers among ourselves. Just before we came on, Denton was talking about some, we were discussing some areas of interest, especially on areas that we will probably have a lot of cases that come through, like in breast cancer or diabetic food sepsis, acute abdomen, trauma, and so on. Thank you.
So thanks. Just one comment to tell you, guys. I think when you research, what would be nice, I guess, for us to help you is to find out for you what is a problem that you're facing in, for instance, in Solomon Island or with the population. What are the questions that you're facing and what you want to find out? So if you get an idea first on what is the problem, how to solve the problem, what is the concern, the background, and what's the aim of research, it will be very good. For instance, yes, you talk about diabetic food, for instance, or diabetics. So what is the problem? And try to when you get a database, it's good to have, first of all, it's good to have data with all the patients you operate. You should have a database, maybe on paper first, of every patient, for instance, man, woman, age, any, are these patients diabetic or not, insulin or not, fat or not, smoking or not. So there's a lot of data that you can actually take before you decide what you want to study. If you get an approach systematic for all the patients you have, and you get a collection of, for all the patients of maybe 50, 60, 70 different information, which are very important. Again, age, sex, obesity, height, whatever it is. And then when you get this together, it's easier for you. If you ask yourself a question about, for instance, I don't know, what's the risk of, with a hernia repair, what is the risk of having a wound infection in our population if the patient is a smoker, or if the patient is a diabetic, or is an emergency versus elective? So I think what is important that you start already collecting every information on all comers through the hospital. Doesn't matter what it is, you take all the information, important information, and at the same time, you try to ask yourself, okay, what is a good research? What should we do? What is important? What are the questions, the issue we're facing in our country that we don't have in Australia, for instance? And then we can help you out more practically about how to achieve your goals. But the database is important, and then try to get the right question. And we can help you, I think, the four of us, we can help you to know how to ask the right question, how to extract the right information, and so on. Does it make sense?
Yes, definitely. Definitely. Thank you.
I think you have to change the culture. If you want data, you have to really change the culture of your unit so that it has to become the norm to collect data. And
Yes.
whether that's on a piece of paper or on a computer, that has to be the norm. Otherwise, it's never going to happen. So there has to be dedicated time, perhaps for your registrar or perhaps for the consultants. And you probably have to pick 4 or 5 things, like you mentioned, breast cancer, diabetic foot, trauma, acute abdomen. You know, maybe even just pick 4 or 5 topics and say, right, for the next 2 years, we're going to collect as much data as we can on these things, and give your registrar a time, say on Wednesday afternoon, right, you're going to get all the data from all those things from this week. Unless there's a culture to collect data, it won't happen. The unit I work in is we've got this colorectal cancer database, which started 50 years ago. So before my time, but it's celebrating its 50th year. So it's just become the norm for us to collect everything there is about colorectal cancer. But that's it's the culture of the unit. And it's not an easy thing to change, but it starts with just picking a few topics and setting aside the time each week to do it, I think. Because you guys could do breast cancer, hernias, trauma. You could look at every trauma laparotomy you do for the next 12 months. And that would be publishable.
Now, I guess the other thing that you could think of doing, just to get it started, is look at case reports, which, you know, I mean, there's a lot of very interesting stuff in the Solomon Islands, and it just can give your registrars a bit of a feel about writing a paper and submitting it, and just getting used to it in that way. And you know, that goes on the CV as well as anything else. So you might want to look at you know, an extraordinary event or something that you think is remarkable that's come through, and do a case report
And we'd be happy to review the papers. We don't want to be co-authors. We don't. That's not our aim. We're very happy to review papers for you without any co-authorship or anything. So if you send them to us via Daisy, then we'd be very happy to have a look.
Good night, everyone. Sorry, can you hear me?
Yeah, we can hear you. Okay, Ian, thanks for coming.
Thank you for the presentation tonight. I think for me, the main take-home message was that we must be able to publish the research that we do. And the challenges, especially in my setting where I am, is the guidance and leadership in guiding us as to how to go about publishing and carrying out these studies with the end result of eventually publishing. And some things that I felt, that are challenging, especially, is that the options for publication, especially for settings where resource limited settings, most of the journals, their scopes, they're looking for new things. Most of the things we might bring to the table might be things that have already been already reported on. So I'd like to, one of my questions, if you could give advice on ways in which we can probably come up with ideas in a resource limited setting to capture the research that we do here. Yeah, that was one of my questions I wanted to ask. Is there any advice for especially researchers in resource limited settings trying to look for topics that would capture these journal scopes, especially when journals options for publication are not very limited. When we talk about big journals.
Konrad, do you want to answer that?
Yeah, no. Can you hear me? Yeah.
Yep.
I think what you said, Peter, and also Chris and Matt, just to start maybe on the 1st of June. I mean, just to start to collect the data of the next 6 months of all patients and put them in a proper Excel data sheet. That teaches you how to do this, number one. And in 6 months, you get data you have no clue about yet, because you don't know what your occupancy is of your beds. You don't know what the common diseases are in numbers, what you're treating. And you already get in 6 months probably a good overview about, in Honiara, the National Referral Hospital, what you're actually treating, how many patients you are treating, how many patients you even see in clinic. Nobody knows it. I know that Scott said he would see 150 patients possibly a day when he goes to Santa Isabel and treats as a clinic. So the Minister of Health needs those data to give money to the hospital, but you can never deliver them because you don't have them. So just to start with something simple would be to collect all patients in the next 6 months, and then you can write this up, because nothing exists in this regard. And you can see what you already suspected, Roni, that 70% of the beds are occupied with patients with septic diseases. And that's why there are no empty beds available for other procedures. You can see this is the incidence of thyroid cancers or breast cancers in this time period. That is actually quite sexy. And I think it can be even published, because there's nothing out yet that tells us what's actually happening in the Solomons.
I totally agree with you, Konrad. I think it's important just to get a database started, get the ball rolling, and it will give you an idea of what you're doing. People will know what's happening. And I think on its own, if it's a first in your country, it's really important. So I totally back up that, Konrad.
Okay. Thank you.
And then the ANZJS, if you've got a reasonable paper, is conducive to publishing it. It's very difficult very difficult for everyone to get into the high impact journals, but the, you know, what we call the yellow comic, the Australian New Zealand Journal of Surgery. Is there a South Pacific Islands journal or not? Gary, Berney?
I know there is a PNG medical journal, but I think it's not sure whether it's regularly published.
Right. Yep. So your options probably are ANZJS, I imagine.
Yes, yes.
Yeah, I sort of understand what you're getting at in that, you know, you look at the journal articles and that there are, you know, lots of papers about different drugs or the robot or stuff like that. But surgeons really value innovation. And, you know, you guys in the Solomon Islands, it's low tech, but if you can describe some innovative ways that you've met challenges, your paper will be, you know, gratefully accepted. So I wouldn't be sort of hesitant about describing what you're doing in any way.
Okay. Thank you.
When you do, we know the editors of the ANZJS, so we can always put in a little, word for you.
That's how it works, Matt.
Okay, thank you so much.
But I guess the take-home message here is really to start collecting data, I reckon. Change the culture so that you collect data on what you do. Think about a few topics and just start collecting the data on it, I reckon. And that whole, if somehow you can organise registrars across, even across areas within the Solomons or across the whole area, if you can get the registrars involved with one of these big collaborative trials, that makes a big difference, because that's given a lot of registrars publications, especially in the UK, and more so now in Australasia. Okay, when's the next webinar, Gaz? You're just on mute, Gary.
You're still on mute.
Second last Tuesday. Hang on a sec. It'll the 22nd of June.
Okay, and what's that one on? I know we've got the. Looking back. Anyway, I'm sure you'll send it out.
Yep.
Trying to find your original message.
It's Professor Rob Fittridge, from the vascular surgeon from Adelaide, good friend of Peter Hewett's, on the diabetic foot, along with Professor Matt Malone from Liverpool Hospital. Both of them have been involved in trying to set up a diabetic foot clinic in Honiara, as well as Mickey Lungi from Kilufi Hospital, and Tabby Ahmed, a vascular surgeon from Liverpool.
Yep. Yeah, that's the next one. Then the one after that's upper GI. Then we've got, we've got diabetic foot. Then we've got biliary disease. Then we've got upper GI. Then we've got colorectal. Then we've got anal conditions. And then we've got plastics. And that takes us up to November. I think someone just asked on the chat group whether this is recorded, Gary.
So I've recorded this. It's not been put in the public domain, but it has been recorded.
So if someone wants to get hold of it, can they?
We probably should have a policy on that. I'm not sure.
I don't mind if it goes on the website. I don't think we've said anything too embarrassing.
Oh, I think definitely this session absolutely. Because we haven't been discussing clinical cases. So I can put this session up on the website if you like, a link to it.
Yeah. I'd be happy with that. Peter, Konrad, Chris?
Oh, no problem.
No. Yeah.
I wonder, Rooney, if you can identify one person in your hospital, an administrator or a so-called study nurse, or maybe to start with Denton, to help you with putting the data in, because you won't have the time. You need to have someone really singled out who is responsible purely for doing this consistently and continuously. You cannot do this next to your work because it will not be complete. It has to be complete. Every patient who comes in for the next 6 months has to be documented in a database. Do you think you can do this?
Yeah, so we are working on that. Dr. Augustine Melia, our new consultant, he's tasked to come up with a database, and he's going to discuss with us hopefully by next week on the how to put in the diagnosis so that it's consistent.
Yeah, time of hospital stay, any details about patients, treatment.
Yeah, so that's what we are doing, and we are sort of trying to identify some registrars to try and look at particular, like somebody starts to look at all the deaths, and somebody starts to look at all the, diabetic foot admissions and so on. So,
can I make a comment? That shouldn't be offensive, but you talked about this 2 years ago. If you ask for a sexy case report, which I think will definitely be published, number one, and number two will be a message to your Ministry of Health, because I remember we were sitting at the same desk you are sitting, and we saw rats walking up the pipes at the tea break, and you said they would actually bite patients, particularly the diabetic foot patients, because they are so sweet. I mean, if you actually come up with a study about this, which is a serious problem, you might get some traction to, get some money to fight the rats in the first place, but also identify a problem in your hospital. That sounds weird to us, I think, but I saw this, and it seems to be a serious problem in the hospital. I'm sure it's still the case.
Yes.
What do you think, Matt?
Have you got rid of the rats, Rooney?
No. I don't think we will ever be able to get rid of the rats.
Wow.
It's true though, like you can't get anything. Your admin will be the same as ours. We ask for things from admin, they say, give us data, give us a business plan. You've got to be able to, data's everything. You ask for something, you got to be able to prove why you need it. So as Konrad says, if you've got rats that are biting your diabetic leg patients, you do a survey of it, you take photos of it, you give it to admin, you give it to the press.
You get this published easy. There's no other study out as I am aware of, similar.
We've got a lot of mice at the moment, not rats.
Yeah.
Yeah. I've had rats in my house. I killed one with a big machete once in my kitchen. Okay, shall we end it there, Gaz?
Yes.
Thanks, everyone. Nice to see everyone.
Thank you.
Yeah, good to see you. All the best.
Bye-bye.
Bye.